I'm Dr Angeline Goh, and today I will be talking about the management of chronic kidney disease and the options for renal replacement therapy. I'm a consultant nephrologist and transplant physician practicing at the Kidney Health Clinic Private Limited, which is located in Mount Elizabeth Hospital. I can be contacted at the telephone number below or the email address below. Upon completion of this module, we hope you'll be able to define chronic kidney disease and its different stages, understand and apply measures on how to avoid acute kidney injury, identify and control the risk factors and complications of CKD, and to provide options for renal replacement therapy to your patients. Over the next 30 to 40 minutes, we will be covering the definition of chronic kidney disease as well as its various stages. We'll talk about how maintaining healthy kidneys and avoiding acute kidney injury helps to prevent CKD. We will identify and control the risk factors for chronic kidney disease, as well as the complications for chronic kidney disease, and finally look at some of the options for renal replacement therapy. Chronic kidney disease, or CKD, is defined as the abnormalities of kidney structure or function, which is present for at least 3 months. This can either be a glomerular filtration rate of less than 60 mL per minute per 1.73 meters squared, or the presence of markers of kidney damage, such as microalbuminuria or microhematuria. We commonly see this value called the estimated glomerular filtration rate, or the eGFR, on our lab tests. It is actually calculated by the CKD EPI equation, and what happens is after we input the serum creatinine into this equation, the computer or the mathematical formula then gives us the eGFR. It is important to note that the estimated glomerular filtration rate is affected by the age and gender of a patient, and we'll take a slightly closer look at this in a little while. These are the various stages of chronic kidney disease as defined by the KDIGO, or Kidney Disease Improving Global Outcomes Group. From stages 3 and above, there is a moderate to very high risk of a patient approaching end-stage kidney disease. And therefore, we recommend that patients with CKD stage 3 and above should be referred to a nephrologist, because it is at this point where we have to start looking for complications and treat those complications. CKD stage 3 is defined as an eGFR of less than 60. As you can see from the graph on the left, once the eGFR falls less than 60, there is an increased risk for all-cause mortality. And the graph on the right shows us that once the albumin to creatinine ratio is more than 5, there is again an increase in all-cause mortality. And therefore, microalbuminuria is also a marker of chronic kidney disease, and such patients should be referred to a nephrologist for further management. In this slide, we will take a look at how gender and age affect the estimated glomerular filtration rate. We have 2 patients, one male and one female. They are both aged 50, but the male 50-year-old patient is at CKD stage 2 with a creatinine of 120, while the female aged 50 with a serum creatinine of 120 is actually at CKD stage 3A. Now we have 2 patients, male and female, both aged 70, with a serum creatinine of 120. The male patient is now at CKD stage 3A, while the female patient is now at CKD stage 3B. So it is very important when we look at a patient not to just look at serum creatinine, but also correlate gender and age to the overall kidney function. As a guide, when you have a patient whose serum creatinine is more than 100 micromoles per liter, or more than 1.2 milligrams per deciliter. So you Google search the CKD Epi calculator, and it will prompt you to input 4 things: the patient's gender, age, race, which is black or non-black, and the serum creatinine, which can be in micromole per liter or in milligram per deciliter. If the patient is then at CKD stage 3 and above, it would be advisable to refer this patient to a nephrologist. Let's talk a bit about maintaining healthy kidneys. The most important thing to do to maintain healthy kidneys would be to avoid acute kidney injury. This is because acute kidney injury, or AKI, increases the risk of new or progressive CKD, end-stage kidney disease, as well as death. A higher stage of AKI puts an individual at higher risk of future kidney disease and death. Now, in addition to avoiding AKI, we also have to control risk factors that worsen chronic kidney disease, such as blood sugar or blood pressure. And in people at risk, for example, the diabetics and the hypertensive patients, regular screening for chronic kidney disease is important so that we can pick it up early and identify and treat complications early. There are various organizations that have come up with different definitions for acute kidney injury, and the most commonly used one is the KDIGO definition, whereby there is an increase in serum creatinine of at least 0.3 milligram per deciliter or at least 27 micromoles per liter within 48 hours, or an increase in serum creatinine of at least 1.5 times from the baseline creatinine within the past 1 week, or a decrease in urine output of less than 0.5 mils per kilogram per hour for 6 hours. This is a systematic review of 82 studies comprising more than 2 million participants, and it shows us the long-term risk of adverse outcomes after acute kidney injury. The results of this systematic review show us that individuals with acute kidney injury were at increased risk of new or progressive CKD with a hazards ratio of 2.67. They were at increased risk of end-stage kidney disease with a hazard ratio of 4.8, and also at an increased risk of death with a hazard ratio of 1.8. The forest plot on the left shows us the increased risk of CKD after AKI, and the forest plot on the right shows us the increased risk of end-stage kidney disease after AKI. These two forest plots shows us the increased risk of death after an episode of AKI. The table on the left shows us that there is an increased risk of death across increasing AKI stages. In addition to this, the magnitude of this risk is also modified by the clinical setting. For example, whether the patient went for angiography, for cardiovascular surgery, or was just admitted to the hospital for sepsis, or even required an ICU admission. The risk is also modified by the patient's baseline kidney function, whether the patient is diabetic or not, and the presence of coronary artery disease. These are some of the more common causes of acute kidney injury, and we'll talk about some of them. Dehydration, for example, after a long run or having walked around under the hot sun for a long time, can cause acute kidney injury, and it is important to advise patients with normal kidney function to drink at least 2 liters or 8 glasses of water daily, and to get them to increase their fluid intake if they're exercising. For patients with heart failure or pre-existing chronic kidney disease, their physicians would be the best to advise them on how much fluid they're allowed to ingest in one day to prevent fluid overload. Rhabdomyolysis or crush injuries is another cause of acute kidney injury, While crush injuries are not so commonly seen these days, rhabdomyolysis, especially from spin classes, has been increasing in frequency. It is important to advise our patients who go for strenuous exercise that they should know their limits, stay well hydrated, and if they do not feel well, or especially if their urine turns dark colored, to seek early medical attention, because rhabdomyolysis can give rise to acute kidney injury. We will talk a little bit more about drugs and drug interactions in the next few slides. Intravenous iodinated contrast that's used for CT scans can cause contrast-induced nephropathy, also cause acute kidney injury. Therefore, for patients who are going for CT scans with IV contrast, it is important for them to keep well hydrated. And for someone whose eGFR is above 60, I would advise them to have at least 2 to 2.5 liters of fluid starting at least 2 days before the procedure. Infections are another common cause of acute kidney injury, and we commonly see patients eventually end up with chronic kidney disease if they have repeated, untreated, or partially treated infections. Even an acute infectious episode can result in acute kidney injury, and therefore this is something that's important to look out for and test, because patients with acute kidney injury frequently do not present with a lot of symptoms, but it is the raised serum creatinine that alerts us to the presence of the AKI. Kidney stone disease can sometimes lead to obstructive uropathy and cause AKI. Pregnancy-associated kidney diseases can also cause AKI, and there are quite a number of them, but which are out of the scope of this talk. Let us talk about two very common nephrotoxic drugs. We'll begin with looking at the NSAIDs, or the non-steroidal anti-inflammatory drugs. While NSAIDs are very commonly used because they are very effective for pain relief, they inhibit prostaglandin production, which leads to a decrease in renal plasma flow, a decrease in glomerular filtration, and eventually causes a rise in serum creatinine. For patients who have CKD stages 3 and above, I would advise them to avoid the use of NSAIDs as far as possible. If they have to take an NSAID for whatever reason, then it's just important that they remain very well hydrated during the time that they are taking the NSAID. COX-2 inhibitors, again, are very effective for pain relief. Examples of these are Arcoxia or Dinostat. The mechanism of action for COX-2 inhibitors to cause renal impairment is similar to that of the NSAIDs. They again decrease or inhibit prostaglandin production, giving rise to decrease in plasma flow, and therefore eventually cause a decrease in glomerular filtration and increase in serum creatinine. For renally impaired patients, it would be advisable to avoid the use of COX-2 inhibitors as far as possible. Even for patients who do take NSAIDs and COX-2 inhibitors whose eGFR is more than 60, it is important to advise them to remain well hydrated during these times, because continued use of NSAIDs and COX-2 inhibitors over a prolonged period of time can cause acute and eventually chronic kidney injury. It is important to note also that when patients take NSAIDs and COX-2 inhibitors, it usually is for pain. And pain is not a water-seeking behavior, because very few people in pain would want to get up, go to the kitchen, get water to drink, and then have to go to the toilet after that to pee. However, adequate hydration is the key here in preventing acute kidney injury when a patient has to take NSAIDs and COX-2 inhibitors. So when prescribing these drugs, please do advise your patients to remain well hydrated. Another commonly used drug is colchicine for pain relief during acute gouty flares. Now, it is primarily metabolized by the liver and undergoes significant enterohepatic recirculation and is also excreted by the kidneys. Therefore, dose adjustment is required in patients who have chronic kidney disease. When we prescribe colchicine to a patient who does not have chronic kidney disease, we can tell them to take 1 tablet every 2 hours and stop when they get diarrhea or nausea or vomiting. However, for a renally impaired patient, we try to limit it to no more than 2 to 3 tablets daily. Colchicine can also interact with statins to cause myopathy, which can give rise to muscle aches. So for a patient whose eGFR is less than 30, meaning that they are in CKD stage 4 and above, and if they happen to be on a statin, I would advise them to stop a statin or to stop the statin that they're taking when they need to take colchicine for acute gouty flares. Another class of painkillers commonly used are opiates. Now, tramadol undergoes 30% renal clearance, so the maximal dose would be 100 milligrams 12 hourly for patients with CKD stage 4 and above, when their creatinine clearance or estimated glomerular filtration rate is less than 30. For patients on dialysis, they should be given no more than 50 milligrams of tramadol twice daily. Codeine phosphate is not recommended in CKD patients because it undergoes hepatic metabolism to active metabolites, which are 90% renally excreted. In CKD patients, the metabolites of codeine phosphate may accumulate, and this could lead to cardiorespiratory depression, decreasing a seizure threshold, causing opioid-induced hypotension, which could lead to renal hypoperfusion, and even worsening renal impairment. Other side effects of opiate overdose include urinary retention and constipation, which is unpleasant for the patient. The next 2 slides shows us some opiates that can be used for CKD patients and those which cannot. In general, tramadol and buprenorphine are the ones that are safer for CKD patients. For the rest of the drugs, it is not recommended for use in CKD patients. Let us now look at identifying and controlling risk factors in chronic kidney disease. In diabetic patients, we all know the importance of controlling diabetes. For those who are aged 75 and below, we aim for a HbA1c of 6.5 to 7%. For those aged above 75, we aim for a HbA1c of no more than 7.5%. There's a higher threshold here because we want to avoid hypoglycemia in elderly patients. We also need to control our patient's blood pressure to decrease the rate of renal deterioration. For those without albuminuria, a blood pressure of not more than 140/90 millimeters mercury would be good. For those with albuminuria, meaning a 24-hour urine albumin of more than 30 milligrams or a urine albumin to creatinine ratio of more than 30, these patients should aim for a blood pressure of not more than 130/80. A healthy diet that's rich in whole grain and fruits, low in salt, would be good for patients for good cardiovascular and renal health. For patients with CKD stages 3B and above, we also advise them to lower their protein intake to 0.8 grams of protein per kilogram body weight per day. And in advanced kidney disease, when there is decreased renal function leading to decrease in urine output, we also have to advise our patients to restrict their fluid intake, and this has to be tailored for the individual patient. A healthy lifestyle, namely physical activity compatible with cardiovascular health and tolerance for at least 30 minutes 5 times a week, is advisable for everybody. It is good for cardiovascular and renal health. Alcohol consumption should be limited to 1 to 2 drinks per day in men and 1 drink a day for women. There is no such thing as healthy smoking, so all patients should stop smoking and maintain a healthy BMI. In terms of the management of hypertension in CKD, we want to optimize, first of all, the dose of ACE inhibitors and ARBs, which are our first choice drugs, because they also have anti-proteinuric effects. What happens is these drugs induces efferent arteriolar vasodilatation, giving rise to a decrease in intraglomerular pressure, and it therefore lowers proteinuria. It has been found that the combination of ACE inhibitors and ARBs is ineffective at slowing progression of chronic kidney disease or reducing cardiovascular events in CKD patients, but instead increases the risk of hyperkalemia and acute kidney injury. Once the dose of the existing ACE inhibitor or ARB has been optimized and the patient is still proteinuric or still hypertensive, we can add on aldosterone antagonists, but it is important to monitor closely for hyperkalemia. There are some side effects of ACE inhibitors and ARBs, although these are our first choice drugs. ACE inhibitors can cause dry cough, so if so, we can just switch the patient to an ARB. They can also cause hyperkalemia, especially in patients whose eGFR is less than 60. So for patients who are hyperkalemic and whose BP control is still suboptimal, we can add on a thiazide diuretic to help the blood pressure control and the hyperkalemia. If their blood pressure control is already adequate, we can add on sodium bicarbonate to shift potassium intracellularly. If the rise in serum creatinine is within 25% when we increase the dose of the ACE inhibitor or ARB, it is acceptable. If necessary for blood pressure control, second and third line antihypertensives can be added, and this can be in the form of diuretics, the cardioselective beta blockers, or calcium channel blockers. The non-dihydropyridine calcium channel blockers, like verapamil, have very mild anti-proteinuric effect and sometimes can also be used to help with ongoing proteinuria. A little bit about the use of combination pills here. Now, because essential hypertension is multifactorial, the use of drugs acting at multiple sites has been found to allow for better blood pressure control. Studies have shown that 30% of hypertensive patients require combination drugs to achieve good blood pressure control, and they are unable to actually achieve good blood pressure control with only one drug. Thus, by using combination pills, it lowers the pill burden for the patient, allowing improved compliance and better blood pressure control. This is a summary slide for monitoring blood pressure in patients with chronic kidney disease. It excludes patients who are above the age of 80, who are kidney transplant recipients, and who are dialysis patients. So we aim to start with ACE inhibitors or ARBs and maximize the dose of this drug until the maximal tolerated dose in terms of the blood pressure, the renal function, and the serum potassium. Once the patient is at the maximal recommended dose, hopefully they have achieved normal albuminuria and achieved a blood pressure target. If they have not, we can then add on a second or third line drug. In general, we aim for a blood pressure of less than 140/90 for patients who do not have any protein or albumin in the urine. For diabetic patients who have albuminuria, we aim for a blood pressure of not more than 130/80. And if they're above the age of 80, then we aim for a blood pressure of not more than 150/90. For non-diabetic patients who have macroalbuminuria, we also aim for a blood pressure of not more than 130/80. And if they are 80 and above, we aim for a blood pressure of not more than 150/90. You do see that we allow for a slightly higher blood pressure in elderly patients aged 80 and above. This is to decrease the risk of hypotension and falls in the elderly. Once we have started an ACE inhibitor or an ARB, it is important to check the serum potassium and creatinine after a month if they are CKD stage 2. If they are CKD stage 3 and above, do refer them to a nephrologist, and we would actually advise to check serum potassium and creatinine 2 weeks after initiation of the drug and after every increase in dose, because there's a slightly higher risk here of hyperkalemia or a rise in serum creatinine. Albuminuria should be monitored 3 monthly in patients with CKD stages 3 and above. There are other complications of chronic kidney disease seen more commonly in patients with CKD stages 3B and above, and these include metabolic acidosis, defined as a bicarbonate level of less than 22 millimoles per liter. They can also develop CKD mineral and bone disorders, and so we have to check their calcium, phosphate, and parathyroid hormone levels regularly. They can also be anemic because the diseased kidneys do not produce so much erythropoietin, and we would aim for a HB of more than 12 in women and more than 13 in men. Because advanced chronic kidney disease is an immunocompromising condition, we would advise patients with CKD stages 3B and above, and especially if they are stage 4 and above, to go for their regular vaccinations. And these include influenza vaccine annually, the pneumococcal vaccine, hepatitis B vaccine, and definitely the COVID-19 vaccine, including its boosters. For patients who have received a kidney transplant or are on immunosuppressants for their glomerulonephritis, they can only receive killed or live attenuated vaccines due to the presence of these immunosuppressants. We move on to the treatment of kidney failure, and we'll look at some of the options for renal replacement therapy. In order to do peritoneal dialysis, a patient would require an operation to insert a catheter into his abdomen, and fluid is then filled into the abdomen and emptied out. This can be done 3 to 4 times a day for continuous ambulatory peritoneal dialysis, or CAPD, or it can also be done over 8 to 10 hours at night for automated peritoneal dialysis, whereby that tube in the patient's abdomen is connected to a tube that's linked to a bag on the machine, and APD happens while the patient is asleep at night. Another kind of dialysis, which most patients or most of us are more familiar with, is hemodialysis. Now, this requires a vascular access and usually happens 3 times a week in a satellite dialysis center, for example, NKF. Each session lasts about 4 hours, and the patient is then hooked up to the machine, and the machine cleanses the blood over the 4 hours of dialysis. Both forms of dialysis, both peritoneal and hemodialysis, do require a lot of commitment of a patient's time. And so the best form of renal replacement therapy would actually be a kidney transplant. The transplanted kidney can come from a living donor or from a deceased donor. This graph shows us that kidney transplant patients live longer than dialysis patients. This is data from Singapore. At 5 years after starting treatment, whether it's dialysis or transplant, more transplant patients remain alive compared to those on dialysis. And those who have received a living donor transplant outlive those who have received a deceased donor kidney transplant. In terms of the projected years of life, whether the patient is white or black or of different age groups, clearly transplant patients outlive those who are on dialysis. Here again, we see that the projected life expectancy 2 years after a patient has been diagnosed with end-stage renal disease is much longer for those who have received a living donor kidney transplant compared to those on dialysis. An ECD transplant refers to a kidney which is obtained from an expanded criteria diseased donor. And this would be someone who is more elderly with underlying comorbid conditions, compared to a non-expanded criteria donor transplant, which means a kidney which is from a 35-year-old motorist who died in a road traffic accident, for example. So clearly, recipients of a living donor kidney transplant do better than that of recipients who receive a diseased donor kidney transplant, but these patients still live longer than patients who have not received a kidney and who remain on dialysis. If you look at the treatment modality for end-stage kidney failure patients who are alive beyond 10 years, clearly we see that it is the transplanted patients who live longer than the dialysis patients. When then is the best time to refer a patient for a kidney transplant? Well, this graph shows us the overall 10-year graft survival for patients who have received a living donor and a diseased donor kidney transplant. A preemptive transplant refers to a transplant that's done when a patient has end-stage kidney disease but who has yet to start on dialysis. While it does offer a survival benefit, and we can see that that survival benefit decreases over time, nevertheless, transplantation, as long as it happens, is still a better modality of treatment for kidney disease, for end-stage kidney disease, than dialysis. So in the past 5 slides, we have seen that transplant patients live longer. And believe me, they do have better health because there is a reduction of cardiovascular risk, and transplantation resolves the symptoms of kidney failure. And they definitely have a better quality of life because there is less restriction on their diet and fluid intake. That freedom from dialysis gives them more time and energy to do regular things like our hobbies, running, swimming, going to the cinema. It gives them a lot more time for that, and it allows them to have gainful employment. All this leads to an improvement in mental and physical well-being. So kidney transplantation is an operation in which the kidney of an organ donor is placed into a recipient who has end-stage kidney disease. This kidney can come from a living donor or from a diseased donor. Compared to a diseased donor kidney transplant, a living donor kidney transplant has a lesser risk of rejection. It offers the recipient better kidney function and a longer graft and patient lifespan because it is from a healthy donor. So there's a higher success rate, and it does eliminate the long waiting time while the patient is on dialysis waiting for a diseased donor. Who can be a live kidney donor? The live kidney donor can be somebody who is biologically related to the recipient, such as a family member, a parent, a child, a sibling. It can be somebody emotionally related to the recipient, such as a spouse, a close friend, or even in-laws. The live donor has to be at least 21 years of age because in Singapore, the legal age to give voluntary informed consent is 21. Donors older than the age of 65 can be considered on a case-by-case basis. Donors should also be free from cancer, heart disease, kidney disease, and other infectious diseases because whatever the donor has could be transmitted into the recipient. A healthy individual only requires one kidney to live normally. And a healthy individual doesn't just mean someone who feels healthy, but if somebody steps forward to be a potential kidney donor, we very thoroughly evaluate this potential donor to ensure that he or she is truly healthy. For someone like that, kidney donation will not affect the health, lifespan, or energy level of the donor. There are no risks to fertility after a kidney donation, and female donors can undergo successful pregnancy and bear children. Donors will need lifelong monitoring, because some kidney donors may develop high blood pressure or protein in the urine, which could predispose them to a higher risk of kidney failure in future. The risk of reduced kidney function giving rise to eventual kidney failure in kidney donors is less than 1%. So we have seen that kidney transplantation is the best form of treatment for patients with end-stage kidney disease. And for a donor who is carefully evaluated, he or she can safely donate a kidney without any negative impact on the donor's health, lifespan, or energy. However, I would put it to you that it is really difficult, especially in our Asian culture, to persuade someone to give a kidney or to even accept a kidney from a loved one. And that is why I ask of you, colleagues, to please refer your patients with CKD stage 3 and above to us early, because we need time to form that doctor and patient relationship. We have seen in the past 30 to 40 minutes that the estimated glomerular filtration rate is affected by serum creatinine, age, and gender. An acute kidney injury increases the future risk of chronic kidney disease, end-stage kidney disease, and death. And therefore, for a patient who has had an episode of acute kidney injury, we would advise this patient to have biannually or annually blood tests to continue regular monitoring of their kidney function. It is important to beware of drug interactions when prescribing new medications to CKD patients. It is also important to identify and control risk factors of chronic kidney disease and to be aware that different complications arise at different stages of CKD. Once again, please refer the patients to your nephrologist no later than CKD stage 3 because we need time to talk to them about the implications of end-stage kidney disease when they are already at high risk of progression to end-stage kidney disease. There are various options of renal replacement therapy, and kidney transplantation is the best form of treatment for end-stage kidney disease. Thank you. These are my references. Thank you for reviewing this module on the management of CKD and the options for renal replacement therapy.